Please keep in your prayers these two families, two couples that I know of, one parishioners in our parish, the second family members, actually first cousins with my mom. It's occurred within the past 6 months, March of this year and then July of this year. I'd like to begin my reflections on this topic with a look at this very familiar painting on the ceiling of the Sistine Chapel depicting, of course, the creation of man. And I'd like us to consider what John Paul II in the theology of the body refers to as original solitude. He teaches that man experiences original solitude in two ways. First, in that he is alone as the only rational creature on earth. We heard from Sister this morning about that. He's aware of himself, he's aware of his body and its meaning, and in his self-knowledge knows that he is created by God and therefore is not God. He realizes that he is not the same as the animals either. But secondly, he is alone in this original solitude also because he is created not to live by himself, but in communion with others, and he feels this acutely without the woman. You can see here, the woman, of course, was part of God's original plan. And as man was made in the image and likeness of God, that is, imaging the relationality of God himself, right? God is Trinity. Man is created also to live in relationship. So John Paul II in the theology of the body will speak of original unity, and through it, one aspect of man's solitude is overcome, another is confirmed. So with that brief background introduction with some of the theology of the body, I'd like to explore this one particular line in Scripture, Genesis 2:18, and specifically from the perspective of what it might say to us with respect to marriage, and in particular the beneficial effects of marriage on health and the detrimental impact of spousal loss. Now this is a huge topic. In our brief time, I'll limit my remarks to the effects of married life on health and mortality, and the impact of spousal loss on health and mortality. And I'll raise two corollary questions, which I'll ask when we get to them. Keep you in suspense. Now, while I will touch on the effects of marriage on health, the more compelling data are found with respect to mortality. Married individuals have lower mortality rates than those not married. And among married people, spousal loss is associated with an excess mortality. This particular study gives us probably the most robust of data sets on marriage and mortality, at least in an older population. 53 prospective observational studies published between 1995 and 2005 with over 250,000 subjects, again, elderly population, age greater than 65 years old, looked at married versus non-married in the various categories shown there. And overall, the risk of death was lower in those who were married. And when broken down into the subcategories of unmarried, there remained a statistically significant effect with respect to higher risk of death in the unmarried categories. You can see the odd ratios listed there. There was no gender difference among any of the comparisons. So in summary, this large meta-analysis and review of marital status in the elderly showed that marriage was a significant an independent predictor of survival with an overall reduction in mortality risk for married versus unmarried individuals ranging between 9 and 15%. What about marital history and not just marital status itself? This study contributes data specifically on marital history. I think that'll become more clear as we go what that means. And so marital history and all-cause mortality. Looking at a little bit younger of a population, men and women aged greater than 50 years old, with nearly 500,000 deaths during the study period. It was in England, in Wales, and Finland. That's where it was. The data sets were pulled from. And these data here show that in men, those consistently married with no record of marriage breakup had the lowest mortality risk when compared to the other groups you could see there. Moreover, those that were divorced or had a history of divorce had among the highest mortality risk. And these are data adjusted for age and then all other factors adjusted, other demographic variables. In women, the data were similar, though not statistically significant, trended in the same direction. So the duration of marriage, long, late, consistent marriages, lower risk for mortality, and tended to be higher in those divorced or with history of divorce. So in summary, those who were married at baseline with no record of previous divorce or widowhood had the lowest mortality rates. Being married and thus having past experiences of marital breakup, that is divorce or widowhood, increased the mortality risks among those currently married. And remarriage after marital dissolution had a protective effect compared to those who remarried, who remained divorced or widowed at baseline. There was also, the investigators found, evidence in favor of a cumulative effect of divorce and of widowhood. And so there is consistent evidence in favor of both protective effects of long-lasting marriage and detrimental effects of marital dissolution, according to this study. So let's examine this topic from yet another perspective. This paper in the New England Journal a number of years ago really got my attention. I remember it to this day. They examined the question is, what happens about, what about when a spouse is ill, and more specifically is hospitalized? So this study examined, and it was a Medicare population, in over 500,000 couples, of whom over 700,000 were hospitalized at least once. And of those hospitalized, 49% of the men died, 30% of the women died, and 18% couples died in 1 year of hospitalization. This table shows the percentage of husbands who died within 1 year, after hospitalization of their wife for a variety of primary diagnoses necessitating their hospitalization. So, for example, the 1 year mortality of a wife hospitalized with colon cancer was 19%, husbands 6.4%, and so on. Draw your attention to any diagnosis, spouse admitted with any of the diagnosis, 13.8% mortality, and the husband's 6% mortality for any diagnosis. That same table now, just looking at when husbands are hospitalized, again with the same disease categories listed here. Draw your attention for any diagnosis, 22% mortality in the hospitalized husbands, less than the husbands, 3.5% mortality in the husbands when their wife was hospitalized. So when these data then are adjusted for other attributes, for example, age, baseline comorbidities of the subjects, we see the risk of death according to the spousal diagnosis. So, for example, the hospitalization of a spouse for ischemic heart disease, for example, or stroke, or congestive heart failure, COPD, and so on, associated with higher risk of death in the spouse. So a spouse who dies in the hospital has a 21%, is associated with a 21% increase in risk of death for the husband, 17% risk of death in the wife. Along the same thematic lines, this recent study examined whether marital status was associated with health outcomes in non-cardiac surgery. These are data in adults age 18 and older, non-cardiothoracic surgery, non-same-day surgery procedures. Study done at Duke over a little over a year period of time. Nearly 12,000 patients were enrolled. This plot shows the 2-year survival by gender and marital status. So unmarried men had a worse 2-year survival after non-cardiac surgery in this study. And these two plots show 2-year survival by marital status in men and in women. In men, divorced men and never married men had worse 2-year survival. There was no difference in married and widowed men. And among women, there were no significant differences among the 4 categories. The magnitude of the effect is shown here in the hazard ratio table. So for never married versus married men, you can see the increased relative risk for death and divorced versus married men, even higher. So although the New England paper on mortality risk following hospitalization of a spouse provided some insight on spousal loss, this particular study examines more closely the potential effects of bereavement duration, age, sex, education, ethnicity, household size, and number of children. And this was an Israeli study looking at census data, comparing with health records. Again, age greater than 50 years old, over 80,000 subjects in this study showed that age-adjusted mortality risk by bereavement duration, revealing that there was a significant risk in men and women that was highest in the first 6 months of bereavement. So 40% higher mortality risk in both men and women. These weren't statistically different, but about 40% higher risk than that of married men, although there was no difference between men and women. Is that clear? And the relative risk of death in men decreased over the age group. So for the men in the men group, the impact was less at older age cohorts. It was fairly constant, that effect across women in the various age cohorts. So with regard to other sociodemographic attributes, this study also found that the bereavement effect remained significant for each age group, decreased with duration of bereavement, even when adjusted for education and ethnicity, and there was no significant interaction of bereavement and education in men. Smaller mortality effect in less educated men, similar trend in women, but not significant. There was no interaction of bereavement with ethnicity or household size. And women with 1 to 3 children showed weaker bereavement effect than childless women. The effect for women with more than 4 children was similar to that of childless women. So these authors concluded that in both men and women, spousal loss was associated with excess mortality, especially in the first 6 months of bereavement. Among men, the younger and more educated were more vulnerable to this effect. Among women, having 1 to 3 children appeared to have a protective effect. Now let's pause for a moment to consider why some of these effects of spousal loss are seen. Well, bereavement itself may have a causal effect in increasing the risk of death. We'll touch on that later. Major role changes that follow spousal death may trigger diseases that may lead to an earlier death. The stress of caring for an ill spouse may cause caregiving spouses to ignore their own health. Some spouses may share lifestyles, right? Smoking, drinking habits, poverty, and so on, that simultaneously diminish longevity. And that's why, as studies alluded to in upcoming, you'll see, importantly, corrections for these factors. What about the mode of spousal death? These are some interesting data. Non-elderly widowers have highest mortality, according to the study, when wives die suddenly, even higher for age 25 to 49, compared with older widowers. And for widows, there appeared to be no significant increase of death. Actually, there was a decreased mortality risk in elderly if death is expected, and these are the data. So focus your attention on unexpected death in men, younger versus older men, significant relative risk increase for mortality when death occurred unexpectedly, and no difference in women, younger women, even if the death was expected or unexpected. Actually, in older widows, if it were expected, it seemed to have mortality reduction effect. So far we've seen that there seems to be a real association between mortality risk in marriage, and specifically between risk and spousal death. But we must consider that this is merely an association, maybe a correlation, maybe a selection effect, and not a causal relationship. After all, as I alluded to earlier, we can appreciate that married couples share similar lifestyles, age, experiences, and so on, behaviors, and so on. So this study set out to test whether they were seeing what we are seeing, simple correlations, or there may be some causation. And just to without getting bogged into, in the interest of time, some of the details about their effects, they made some assumptions about, again, controlling for socioeconomic factors and other things. And they concluded, though, from their paper, the fact that the bereavement effect is as large as it is for surviving husbands when their wives die from uninformative causes that you would not expect, that is, causes of death that reveal little about the survivor. These authors suggested that the bereavement effect actually may be causal. What about marriage effect on health? What are the health implications? Well, married individuals are generally healthier than unmarried individuals. Why might this be? Any of a number of pathways of spousal influence I listed here. We could talk about this in a separate lecture unto itself. Behavioral changes, physiologic changes, so on, emotional support, social dynamics, economics, and so on. All they come to bear on one's physical health. And from a variety of studies, albeit these are relatively old studies, you wonder, based on some of what we heard this morning, whether you'll be able to do studies on marriage these days. Anyway, older studies, many of them based on old data, will find the following positive effect of marriage on health: less decline in vitality and mental functioning, fewer long-term illnesses among men and women in their first marriages, higher initial marital stress speeds, onset of hypertension for men and women, and we can go on and on. Better health outcomes for married mothers, marital status negatively associated with numerous health problems, as we've been hearing. Widowed men, even in more recent studies, at higher risk, divorced men and never married women at lower risk, and so on, for disability. So one more relatively recent study examined the relative impact of marital status, relationship quality, network support on ambulatory blood pressure, and their associated implications for cardiovascular disease and mental health. And the second aim of this study was to examine whether a supportive network could compensate for being unmarried or in a low-quality marriage. You can see some of the methodology here. They excluded unmarried, cohabitating, and pregnant women. Age range you can see there. These investigators found that there was a greater change in blood pressure dipping at night, which is a good thing, in married compared with single persons. Moreover, married individuals had greater satisfaction with life and blood pressure dipping than single individuals. Higher marital quality was associated with lower ambulatory blood pressure, lower stress, less depression, and higher satisfaction with life. Contrasting those who were unmarried with those in low-quality marriages revealed that single individuals had lower ambulatory blood pressure, suggesting that single individuals fare better than their unhappily married counterparts. And having a supportive network did not appear to buffer the effects of being single or unhappily married. And while the investigators in their paper go on to say that they expected to find similar benefits among single persons and those with low-quality marriage, they found no evidence that a supportive network buffered the effects of an unhappy marriage or being unmarried. So being married per se did not have a universal benefit, if you will. Rather, the satisfaction and support associated with such a relationship that is married is important. And marriage may be distinctive as support from one's network does not compensate for the effect of being single. This is one of the important corollary questions that I alluded to earlier. The data here are extremely scant. What I did find concerns a psychological distress score, where the lowest distress score was seen in heterosexual marriage. I guess I could just say marriage. And their data, when adjusted, married heterosexuals had the lowest of the psychological distress scores than lesbian, gay, and bisexual persons who were not in legalized relationships. That group had the highest psychological distress score. This study, again, the data are very scant. This study used pooled data over a decade, National Health Survey, self-rated health scores among same-sex cohabitators and different sex couples. The analysis involved three different logistic regressions. That's why you see the models here. This was unadjusted, so just raw scores. These were analyses, data from adjusted for socioeconomic status, and this was adjusted for not only that, but race and ethnicity. So the results here, and I highlighted them here, lower numbers, good. Results indicate that different sex married had lowest poor or fair health rating scores when controlled for, as I said, socioeconomic status and race ethnicity. These are in men, and in women when controlled for socioeconomic status, at least the statistically significant findings. So why is this important to me in my practice? You might ask. Well, perhaps it may enhance the care of our patients, and especially when there is marital discord or death of a spouse. It may be appropriate, depending on our situations, to use these data in professional counseling. What are the take-home points? Well, there's a correlation between mortality risk and marriage. Limited data may suggest causal relationship. Marriage confers certain health benefits, and being unmarried appears to be associated with increased mortality risk. Insufficient data are available to make mortality risk claims with same-sex unions. Though limited data sets, imprecise data analysis, and methodological limitations remained, and there are shifting social landscapes with changing attitudes towards marriage, it nonetheless remains importantly true that marriage is a primordial sacrament ordained by God for human flourishing. Another corollary question then, should everyone be married? Well, in response to this question, let's look again to St. John Paul II and what he wrote early on before he ascended to the papacy in Love and Responsibility. The person is not finally and completely satisfied simply by union with another human being, considered in the perspective of one's personal eternal existence. Marriage is only a tentative solution of the problem of a union of persons through love. And in the theology of the body, he again reminds us of this. On the basis of the same nuptial meaning of the body, male or female, there can be formed the love that commits a man to marriage for the whole duration of his life. But importantly, he reminds us that there is also can be formed the love that commits man to a life of continence for the sake of the kingdom of heaven. Keeping in mind also, it's not good that the man should be alone. We must remember, not all are called to be married. Thank you.
So we have some time for questions. Does anyone have any questions for Dr. Traveling? Wait till I get to you with the microphone because we're being recorded. So,
I just had a question. Sorry about my voice. I just had a question about the bereavement process. In my practice, when a spouse dies, I've always just allowed a spouse to just sort of go through that process in the hope that things would just eventually over time, and that interceding with an antidepressant might be a bad thing. And I'm just kind of wondering if I should rethink that and intercede in terms of mortality with an antidepressant rather than allow the patient to go through the bereavement process over a longer period of time rather than giving him or her a medication.
I'd like to reflect that back perhaps to any physician or therapist in the audience first. Anyone that may have more competency in that area for prescribing antidepressants in someone after as part of a bereavement process. No? Okay. My sense is not, but I didn't look for that specifically data-wise to see if there's any support, medical support for that. So I can't give you an answer based on data. It wasn't my focus in this talk. My sense is, though, not based on just these data that I looked at. None of those papers even suggested that these were more like epidemiologic and didn't get into the weeds, so to speak, with therapeutics, nor even suggest that.
even though I'm not an expert in that area, I can say that it is better that we as physicians facilitate and teach our patients how to grieve, because I think a large segment of our society never learns how to do that appropriately. And that's why the bereavement process, in my opinion and my observations in 37 years of my practice, have seen people who have prolonged depression over bereavement. And I have a personal family member whose husband passed away 28 years ago, who is still severely depressed and has never finished her grieving process and has been to multiple psychiatrists and psychologists and tried antidepressants, and it's not helping anything because she's not getting through the process. And the best thing that I can refer you to is Elizabeth Kubler-Ross's On Death and Dying, and helping facilitate and talk to our patients about getting through the process rather than modifying it or nullifying it by medicating them and perhaps giving them other side effects and delaying it.
Thank you for that question. Just thinking that is an excellent question, and sort of on the heels of these sort of data, it sort of calls me to maybe look into that. So, for the individual in the clinic, what to do. Thank you.
I would recommend that they attend daily mass. God is the ultimate healer, and if that patient happens to be Catholic, I would recommend that they go to daily mass.
I think that's an excellent recommendation. Among other spiritual exercises. Yeah.
Yeah, thank you for the presentation. It's not only informative but enlightening. I'm a gastroenterologist, and you mentioned about incidence of colon cancer.
Oh, yes.
As one of the mortality there. I get two-part question. One, is there any statistical difference among the mortality rate between the non-married and the divorced? And then the second part is, what's the most common cause of mortality among those individuals?
That it's always easy to answer the last question first. That study did not look at any cause of the spouses who died. Okay. Right. They adjusted for comorbidities, and then you saw the relative risk increase in certain disease categories. Colon cancer wasn't one of them, by the way, although I highlighted that when a wife, for example, was admitted with colon cancer and the husband vice versa, there was an associate. That was the percentage of the men or women that died, the percentage, like that 6% were just the raw percentage of women or men that died. When we looked at the relative risk increase, which is really not the point, but is the index for looking at the increased risk. For colon cancer, it didn't matter. In fact, I don't think any of the cancers did it increase the risk. It was ischemic heart disease, COPD, heart failure.
So probably it's cardiovascular is the number one cause?
I suspect, right. I mean, then you can fall to like the age demographic, and that happened to be a Medicare population. I think the average age was 75. So then you can look at then just the most common causes of death in those categories.
Okay, and then the first question, any difference between the married and the divorced?
None of those studies, I presented pretty much what I thought were the best and, more recent of the studies. None of them looked at diseases like that New England paper did. Thank you. As I said at the beginning, this is a huge area, and there's so much to mine there. They didn't look at disease-specific causes there. Yeah.
I don't actually expect you to answer this question,
okay.
So I'll
but ask it anyway.
It's somewhat speculative. Do you think that this sort of mortality, for if a spouse dies, then you subsequently have an increased risk of mortality? Do you think that was true 100 years ago, 200 years ago, 300 years ago? And if it were not true, like I think about sometimes, we read about the lives of the saints. My husband died and I went to found a religious order. Were it not true, what does that say about our contemporary culture and our focus on this present moment rather than the next life? It's a speculative question, and I don't expect you to give an answer, but it's somewhat of an interesting thought. It is
an very interesting thought. Thank you. In this case, I go to answer the first question first. I suspect, I sort of suggested, I don't, suggested if it's sort of, God ordains marriage, it seems to make sense. If that's somehow part of the mechanism, if you will, behind this, then 100 years ago, 1,000 years ago, it probably is the same, right? That if your spouse died 200 years ago, the impact probably is the same, whatever that. Does that? Yeah. So I speculate. That would be my guess, if based on what I said at the outset. I hesitate to say, to emphasize this so much because how many, we probably know more people, like just in our own lives, who have died and whose spouse has gone on for decades, right? Many years. So I was aware of that. And I think that needs to be said. I mean, all of you, no doubt, were thinking that, I suspect. But nonetheless, they are intriguing data when you look at researchers that, sort of ask those questions. And I was trying to tie it in with theology. Jose, wait for the microphone so we get to. But thank you.
Forgive me for speaking from personal or anecdotal history. I was widowed in 2000 with 2 preteen children. At the time, I was lukewarm in my Catholic practice. It took about 2 years to be advised by this wonderful woman, who's now my wife, saying, you ever had a mass said for your wife? You ever said a rosary for her soul? And in the process of trying to be once again of self-giving, what happens when we die? I mean, when someone dies, but we do focus on ourselves. We turn inward very often. And in that process, we forget that self-giving part, that is part what makes us wake up in the morning, to be self-giving for our spouse. I mean, I had my children, but there was a difference there. When I started praying for the soul of my dead spouse, something started. Prayer started for one, and it may be something you recommend, to your patients. But aside from prayer, we know that even though we're praying for someone else, prayer changes the one who prays. And even though you tell them you should be praying for your dead spouse, you're really indirectly saying, this will help you as well. So that's a big part. Now that I see this data, I'm glad I didn't know some of this mortality risk at the time. Thank you.
Jose, thank you for that witness. And it's a perfect segue to 2 things I'd like to leave you with. Les, would you mind handing? There are 2 pages. This is a supplement to the president. There are 2 pages. So every two per person. And one, as I was going through this, this was in the Journal of Clinical Oncology in 2004. A medical oncologist who lost his wife, and this is just an excerpt from his paper. And I printed there, so you don't need to read it on the side. This is what's being handed out, if you care to read that. And I mean, in some, it spoke to how it enriched him in his practice. We heard enriched him in his practice in caring for patients, what he learned after the death of his wife, clinical oncologist Dr. Beatty. And the second from Viktor Frankl, of course, famous Man's Search for Meaning. And just read this as well at your leisure if you like. Again, it's coming in the handouts. And it touched on what I think Jose said to some extent. Just give you a moment to digest that. The point, I think, from Frankel's writing here that we take with us is, in some way, is the last sentence, in some way, suffering ceases to be suffering at the moment it finds a meaning, such as the meaning of a sacrifice.
Any other questions? May I ask one?
Please.
Did you notice, was there any mention in any of the literature that you looked at about the faith of the married couples compared to others?
No. But the short, direct answer is no. Again, epidemiologic studies, looking at data sets. But I obviously know where you might want to go with that, right? But not in these data that I pulled. Yeah. Yeah.
Anything else? Well,
What would be your take-home message from this conference?
From this conference or this talk? This talk?
What is your take-home message that you can give us?
I can go back a few slides. No, I think we need to be sensitive. I think we do well. We enrich ourselves as physicians, as clinicians, maybe in other disciplines, or just as human persons dealing compassionately with other people, to be sensitive to the impact of spousal death on an individual. Of course, we know that, but I think it gave a little more meat, if you will, a more scientific data, albeit epidemiologic, sociologic data. It gave a little more substance to what I think we know in our hearts, that it's a horrible thing to lose a spouse. So I think a greater sensitivity is what I would hope we walk away from this with. And knowing that smart people looked at these and are still looking at this in this area.
So, John, thank you for the talk. I'm getting a lot out of these post-talk questions. I mean, it's having a profound effect on me. What this gentleman shared, and circling back to your title of your talk, it's not good that man should be alone. And it seems to be coming together for me in my mind, and I'm just going to share what I'm thinking, and I'm not a teacher of the theology of the body, but the reason that it's not good for man to be alone, in my humble understanding, is not so that he wouldn't be lonely, but because he's meant for self-giving love.
Yes, true.
And when your spouse dies, your primary place to give that self-giving love has been removed. And perhaps that's a very difficult thing to move on and find another way to direct, especially if one is not aware of it. And I think that is where a physician, and obviously in my specialty, not going to be much help, but that is where maybe it can be a take-home, take to your office kind of message to say this is, and it also juxtaposes with Viktor Frankl, with what he's saying.
Yeah,
right?
you don't stop loving, right?
Yeah,
It still
and I'm not sure he
becomes-
understood the theology of the body, but the idea that the giving it meaning kind of takes away the suffering, I'm not sure it takes it away, but it's why we're here. We're meant to be godlike. We're meant to be divinized. We're meant to pour out.
Yeah.
And if we lose that avenue, that could have a bad effect on us.
Yeah. Yeah, but I would just qualify. I think you're saying that though, but this, I mean, just again, I think he illustrates it nicely here that the suffering becomes a sacrifice. So it still is about love and love for the spouse. So,
I think some of this ties in with the lecture we heard earlier today about the decline in marriage in America today, and I think it's just something we really need to pray seriously about, because man and woman are not meant to be alone, and they're meant to be in a self-giving relationship. And even for all of the John Pauls of the world, his life was of self-giving.
Of course.
And so our young people today really don't understand that their life will find meaning in self-giving. And in most instances, for most of us, that needs to be in a marital relationship with all the blessing that it provides.
Thank you. Other
Anyone else?
comments, please? No.
Well, we'd like to thank you all for coming, and I'd like to thank Dr. Traveling for an excellent presentation.